lot of expansion now, and we're enhancing the quality of the service, both from when a person waits through to when they see the doctor. So, for example, we're putting in air conditioning units in most health centers now.
Okay.
Usually people have to sit down and wait, and it's hot and so on. We're making sure bathrooms are clean, water is running, toilet is flushing. People need to understand is that therapy starts from when you enter the building. Start when you see the doctor. Wait is always going to be a factor of health services because of the triage process. As you know, as a doctor,
yes.
You come into a facility, you have a headache, you think you're dying, the doctor triage you or the nurse. Somebody will come in a gunshot or a heart attack, they're going to go right past you because they're in a life and death situation. My announcement recently that we're going to build a new KPH, we're negotiating some land now, but there's also some move afoot to renovate a number of the existing structures, operating theatre, ICU, some wards. So KPH has done a really good job, and I want to commend you and the people there because truthfully, without KPH, things would be so much worse. It's a primary trauma center in the Caribbean. So, despite the challenges, big up to all of you.
In Office with Dr. Javan Samuels.
Welcome to another episode of In Office. I am Dr. Javan Samuels. Today in Office, we have a very special guest. He's the esteemed Minister of Health and Wellness, Dr. Christopher.
Yes, sir.
Welcome to In Office.
How are you, Doc?
Yes, I'm fine, thank you.
You're the real doctor.
Alright, I'm fine. Alright, thanks very much for accepting this invitation. Alright, and I know that you are actually big on promotion, health promotion, so I'm happy that you did accept this invitation. But before we get in, I just wanted this interview to be about the healthcare services that are available in Jamaica. And I know you are the ideal candidate to really tell the country the different services that are available, right? But before we get into the different healthcare services that are available to the public, what exactly is the role and the responsibilities of a health minister?
Okay, well, a health minister really is part of the executive arm of government, which is the cabinet, and the cabinet is responsible for driving policy around healthcare. So I have a ministry with many agencies, with many technocrats, with many doctors like yourself, and my role is to look at what needs to be done to serve people of the health space, take those into cabinet, get them approved, introduce laws and policies to support the betterment of healthcare. So that's in a summary of what we do. Okay,
alright, so let's dive straight into it. Let's look at primary care first, alright? We know that the leading cause of death is the cardiovascular diseases, second, and then second in line we have different forms of cancers, and some of these illnesses are mainly preventable cause of death, alright? What are the current policies that you have in place for health promotion to help reduce these illnesses?
Alright, so yes, cardiovascular disease. So what that cardiovascular disease falls under the non-communicable disease category, as you know, which really, if you want to simplify it, is lifestyle related disease.
Yes.
So as a country, as a people, we tend to consume a lot of salt, sugars, fats, tobacco, alcohol, and those affect our entire makeup. The government's policy is twofold. One is on the prevention side. So we promote through the primary healthcare system screening and more screening. So we have our Know Your Numbers program.
Yes.
We promote physical activity like our Jamaica Moves program. We promote visitation in homes and communities through our community health aides to help to stimulate and encourage health-seeking behavior. And we do some curative services in the primary healthcare service too. So persons who are hypertensive can go get their regular checks, get their medication through the NHF and the pharmacies that are available. So primary healthcare really is a community-based approach to keeping in touch with the people, and the policies are geared towards encouraging and engaging people. And if they have to be treated, they are provided with treatment in collaboration with the National Health Fund. Of course, the hospital is a secondary level, and that's where people go for more curative services.
Okay, so at present we have enough health centers in the country to adequately.
Yeah, I mean we have 325 health centers, and they are supposed to be located within 10 miles of every residence.
Okay.
That's the original concept adopted from the British system. People have moved all over the place now, so maybe you are out here and there. We keep adding as populations expand in order to accommodate those that are with the rest of the size. So right now, for example, we're building out a much bigger health center in Old Harbour, St. Jago, Portmore, Maypen, and St. Anne, and St. Anne's Bay. Largely because those populations have expanded and we need bigger services. So we have a number of them, as I said, 325, but a lot needs upgrading and expansion, and that's why we're on that expansion mode.
Okay, set off that. So in terms of primary care in Jamaica, I know that sometimes there's some persons complain about the lengthy wait, not just at the hospital, but at health centers, they have a lengthy wait, and sometimes the public facility not open late or on the weekends. Mm-hmm. So these persons that cannot afford private care, what do you plan to have in place to minimize the wait time in the current system in Jamaica?
Well, the wait time is a function of how the demand for health services evolve over time. So there was a time when a particular health center did not have wait, but because population increased, then more people come, then you have wait. Just as I said, if you take Old Harbour, for example, where a lot of housing development has been built out, we are now putting in a $650 million health center. You don't normally hear about a health center for $650 million. It's quite big. It's almost like a mini hospital. It will have lab services, pharmacy, more doctors, more nurses. So the strategy to address long waits is to be more efficient. That's why we're digitizing our health records. Build larger establishments, put more doctors and nurses. We're adding another 350 doctors in our primary healthcare system. It is a moving target, because as you build and expand, the demand changes. But I think the government is embarking on a program now like none before, where we're really expanding our primary healthcare facilities.
Okay. And is it a case where we have outgrown the primary care system in such a way that we need several additional facilities and doctors? What have caused this lapse in the time frame, right? The country.
Well, the truth of the matter is that for the last 20 years, we really have not done any major overhauling of our health systems or our assets. This government over the last 9 have done more to expand infrastructure than any other since independence, both hospital and health centers. So we have upgraded 138 health centers over the last 5 years at a cost of $4 billion. So what I would say is that we're kind of playing catch up because of a long history of neglect, and maybe it's because of our debt situation in the past where health was never seen as a priority. What we're doing right now is really because the government has been more prudent. We're trying now to see how fast we can get to a point where we optimize the services. But it's going to take time, and it has taken time, but I think we're moving in the right direction.
All right. Now, in terms of primary care, we know that the facility, all right, in terms of, like when you're overseas and you're seeing some health facilities, the upkeep of the facilities, for example, the painting, the bathroom facilities, the furniture, etc., are like a little higher standard than, say, Jamaica. But what plans do you have in place to upgrade in terms of the infrastructure, the physical infrastructure? Okay.
Well, higher standards is a relative concept. I think you have to be careful that we don't judge standards with modern buildings. The standards is largely a function of service and a function of the enabling equipment to provide service. As I said, we're doing a lot of expansion now, and we're enhancing the quality of the service, both from when a person waits through to when they see the doctor. So, for example, we're putting in air conditioning units in most health centers now.
Okay.
Usually people have to sit down and wait, and it's hot and so on. We're making sure bathrooms are clean, water is running, toilet is flushing. People need to understand is that therapy starts from the end of the building. Start when you see the doctor.
Yeah, definitely.
And what we're doing now is making the environment a lot more comfortable under a program called Operation Refresh. Wait is always going to be a factor of health services because of the triage process. As you know, as a doctor, you come into a facility, you have a headache, you think you're dying, the doctor triage you or the nurse, somebody who come in a gunshot or a heart attack, they're gonna go right past you because they're in a life and death situation. So I don't know how you avoid wait. The matter is how you prioritize who waits and who doesn't wait when lives depend on it,
All right. In terms of technology in the healthcare system, because I know that it's technology is so advanced, and in my opinion, Jamaica is actually lagging behind in terms of technology in healthcare. In terms of some health center hospitals still using the old manual docket system. What's the time frame we're looking at to modernize the healthcare system in terms of technology?
So interestingly, we are the first country in the Caribbean that is now digitizing our health records. So if you go to Maypen Hospital, it's fully digitized. The health centers around Maypen, Spanish Town digitized, St. Diego. So we have 4 hospitals now that are being digitized on a new arrangement. 125 health centers that are putting in technology platform. And what that means is that they're going to be networked. So when you go to a health center, your docket is uploaded in the cloud. If you're at the hospital, they can retrieve it. It's going to be phase 1 of several phases. So we're catching up, we're moving in the right direction.
Okay, all right. Since I don't have a lot of time, Minister, I want to now move over into the hospital setting, which is secondary care.
Mm-hmm.
All right, and hospital setting, we have this lingering bed space. I'm not going to talk about the facility in terms of the infrastructure at the hospital again and the medical record, but we have a bed space issue at the hospital, which some of the factors behind this lack of bed space is that some wards probably need to refurbish or close down. Some bed space are occupied by social cases. What are the plans to actually make more bed spaces available at the moment?
Right. So we have added about 440 new beds since I've been minister. We have about the same number to add in the next couple of years. We're about 4,000 beds in the system originally. Again, the demand for beds have outstripped the supply of beds. And then you have about 5 to 10% of beds taken up by social cases, people who really should not be in the hospital, as you know, but because they don't have nowhere to go. And the public health act don't allow you to put them out on the street, and there's no infirmary space. So we kind of have to be juggling that. But the additional bed space is going to come from Spanish Town Hospital build out with another 120 beds. Cornwall Regional with another 30 or 40, the refurbished Cornwall. Western Child another 250. St. Anne's Bay will add some. So we are actively now building out hospitals that will lead to more beds. Now, will that be enough? It depends on the sick profile of the population. And it depends on the season. So if you're in flu season, you have you'll never have enough, but you kind juggle to try and have an optimal level so that there's always some capacity in the system, even if you have to transfer patients around. But we are adding beds now.
Okay. I'm happy that you mentioned that it's 5 to 10% of bed spaces are taken up by social cases. Mm-hmm. But I admire how you had handled the COVID-19 pandemic when we don't have any bed spaces. Mm-hmm. You actually made field hospitals, etc. So why we don't have a similar model for like a field hospital to accommodate the social cases temporarily until the relatives come for them or till they can get a nursing home, etc.?
The problem with putting in alternative facilities just for social cases is that you have to also have the personnel to man them, and that's kind of difficult when you have shortage of staff. Also, one of the last signals you want to send from a policy perspective is that you're converting your hospitals to becoming infirmaries. I mean, if people discern that you're going to create separate entities to house social cases, can you imagine how many would line up at your gate wanting to benefit from the daily services of the hospital? It's not a trend. How the system is built now is that you put infirms into infirmaries, and that's controlled by local government. And we have done a lot of that. And collaborated with them, but the truth is it's never enough. I think what needs to happen, if you were to ask me, is that we need to change a lot of hold people accountable for their families and loved ones. So if, it's interesting, when some of these people die, a family member turn up with asking for death certificate because they want to go claim their house and their bank account, but they don't come and look for them when they're in the hospital. And I think that is cruel. And literally during the holiday season, Christmas, people drop off them loved ones at the hospital so the hospital can take care of them. So we have to find a way to hit the culture and change the kind of dependency syndrome, if you will, while still helping those who genuinely need help, but rightfully they belong in an infirmary.
Alright, I want to move along from there. I want to touch on us, because this program, I also interview like different set of patients, and one set of patients that I really have concern for is those persons of end-stage renal disease and the hemodialysis. It's the government system at the hospitals cannot accommodate all the cases of the dialysis that is required. Now, is there any program they have available to help offset some of these costs for some of these patients in a private setting?
Yeah, so we have that. We the compassionate grant. I just looked at the numbers yesterday actually. Over the last year and a half or so, we have spent maybe 50 million or so, 50-60 million over 2 years to support people with renal failure, fifth stage renal failure who need dialysis, by giving them compassionate support to source it privately. And as you know, we have a few thousand, maybe 3,000 or so in the public health system, who depend on the system. The challenge with renal, with dialysis, is that it's really the end stage unless you get a kidney transplant. It eventually kills you, and it's very expensive, and you really have to tackle it, I think, from the supply side, meaning kidney disease, hypertension, the things that facilitate and hasten renal failure. And that's why primary healthcare is so important, because we have to get more Jamaicans screening, so when they know their health status, they know how to take precaution. And I don't see any way around it, because if you continue to live vicariously with the drinking and the smoking and the sugars and fats and salts, you're going to end up there. We have about 150,000 people who are third to fifth stage renal failure. That's a disaster that is happening in front of our eyes. So maybe that's what we need to encourage people to do while we continue to give some support.
Alright, so how can persons access this compassionate fund?
Just apply online. An online application, and it goes to a committee, and they consider it and they make a decision. But I tell you, even if you give somebody $1 million, right, at 15,000, 12 to 15,000 per session, 2 or 3 sessions a week, that run out in a month or less. So you can't have enough money. I mean, it's just a very difficult situation, you know. So that's a real challenge with that one.
Okay. Another set of patients are the cancer patients, like needing chemotherapy. And what measures are in place for them? I know that some patients terminal, but at the end of the day, we still have to try and let them live as comfortable and as long as possible.
So when I took office, we only had 2 cancers that fell under the National Health Fund. Today we have 5. We've added 3. Multiple myeloma, lung cancer, and one other. I don't remember what it is. Anyway, the point is that we are now catering to more cancer patients. Cancer, by the way, is the fastest increase in disease profile, even though it's not the largest category. And a lot of it is nutrition related, lifestyle related, you know, processed foods and so on. And we have to tackle it from that side, which is why we have our nutrition policy and programs for schools and so on. We continue to provide support. A lot of money is very expensive. And then of course we have the radiation, the Linac machines, one in St. Joseph's, one in Montego Bay, that provides radiation therapy to the advanced cases.
Okay. Alright, Minister, I'm seeing you're looking at your time now, but I mean, I'm actually have to touch on the staff a little, because I mean, actually I've told a few of my colleagues that I'm coming here to interview the Minister today, so I have a lot of questions from them to ask.
That's right.
Alright, so the first
question... ready for interrogation.
Alright, so the first question comes like from the nurses. They complain that they are not having the correct staff to patient ratio, because the staffing is not enough, right? And they are criticizing you that you're saying that we have enough nurses, we just don't have enough specialist nurses, but they are telling me otherwise, that on the ward there is not enough nurses on the ward, so general nurses. What's your take on that?
All right, so it's not a untruth that we don't have enough specialist nurses. It's a absolute fact that the biggest area of shortage is specialist nurses, and you only need to go across. You're at KPH, you only need to go across the picture in the neonatal unit, and you realize that you're supposed to have a ratio of 1 to 1 or 1 to 2 sickly babies, and sometimes you're 1 to 4, 1 to 5, 1 to 6, which is a real risk to me, right? I would say the same for operating theatre and all that. So that to me is really the major weakness. So I'm not saying anything that's not the case. The regular RNs, there are some areas where you have gaps, partly because some people may not want to work in certain parishes. You go to Sab or Portland and those places, nice parishes, but sometimes people don't want to move and go to those parishes. I don't know that you have gaps in the urban centers like in Kingston. If that is the case, I would love it to be brought to my attention. We just went through a compensation review program which sought to right size the number of workers to patients, including nurses. And regular RNs was part of that categorization. So if those posts are filled, then you really should not have the challenge that other categories have, unless they're not hiring for the posts. And that is something that I'd have to check with the regional authority. And in other words, if you have 10 posts, they need to fill the 10 posts. Or maybe they might fill 5 or 6 or 7, and I don't know why they wouldn't fill all 10. So what I would say to those nurses or that institution is find out what are the number of allocated posts to that institution and make sure that they are filled. And if they are filled and you're still having problems, then it's something we may have to look at, but that is what my understanding of the situation is.
Okay, all right. So one question from the doctors, I don't have enough time. Do you think that the latest reform in terms of the doctors' classification was that the doctors were supposed to get posts instead of being on contract? A few doctors say they're still on contract and not getting a post. So what's the reason behind that?
Yeah, again, that would have to be examined a little closer, because again we put on the system, I think it may be about 1,200 doctors, new posts, and nurses it's closer to 1,500, I think. These are people who would have normally been on contract, who now have permanent posts. If there are additional people who are on contract, again I would have to see what those are or what categories those are and why. But more than any other administration, we sought to right size the posts with the worker. Before my time, half the working population in the health system was on contract.
Okay.
And that's not the case now. So there may be 1 or 2 that are still on contract, but it should be substantially solved based on the last compensation review period.
Okay, I'm going to try and squeeze in 1 or 2 more questions. So in terms of the compensation, I know that the healthcare workers got a large increase recently. However, is there a plan to actually get the healthcare workers and a similar salary scale to the overseas counterparts so we can prevent the brain drain migration of healthcare workers? What's the plan, future plan for that?
That's an interesting question you asked. So I'm glad you accept that there has been a big increase.
Yes.
But what you need to appreciate is that nothing stays the same forever, because the truth is that the competition for healthcare workers, particularly the ones that are scarce with overseas entities, North America, is so intense that if you move to 10, then move to 12. If you move to 12, then move to 14. And it's a constant movement. Truthfully, we don't have the capacity to sustain that kind of competition. So it's hard for you to say, can we move to the overseas number, because the overseas number keeps moving. And I know, because I'm in touch with them, so I know that they will offer whatever they need to offer. And they're not only offering money, by the way. They offer immediate green card or permanent residence, spousal relocation, housing. That's how desperate they are, and the truth is they have more resources. So our approach is to try and improve working condition, which is why we're building out I think there's some issues around housing and so on needs to be dealt with. The compensation is a livable wage as opposed to trying to beat somebody else. And then over time, we're hoping that we can do some cross collaboration around training. So we expand the pool of labor rather than just competing for the labor. So that's a policy, which is why I went to India, the Philippines, Nigeria, and that's why some Nigerians educators came in recently to try and see how we can collaborate around training.
Okay. All right, one final question. I mean, you did well over the COVID-19 pandemic and in terms of keeping up to date in the nation, right? But one aspect which I think that you could have probably done a little bit better is like communicating with the different associations, the Nursing Association, Medical Doctors Association, Consultant Association. Because normally these groups have to take action, industrial action, for you to really sit down at the table or give them attention that they are requesting. What's causing this lack of immediate communication with these groups?
Again, a kind of cynical approach, but I didn't know that I did not communicate enough. The COVID was a very difficult time and a very unusual time. So you ended up, it's a crisis of 100-year crisis. It wasn't always possible to be meeting with everybody as much as you tried. You tried to communicate as much as possible to the country, which is why we had press briefings twice a week, COVID conversations. You had to confront a lot of noise. Noise meaning distractions. Even doctors were claiming that you could cure COVID by putting salt in your mask and taking, some other medication and so on. We had to be driven by the science. And our healthcare workers remain the heroes of the battle, especially those on the front line. And we tried to cater to them. We had relief sessions for them. We had gatherings for them. So I don't know. I mean, I don't think the response was perfect, but under the circumstances and given all that we had to do, we gave it our best shot, and the results is there to show. We had a lower death rate per capita than most large countries in the world. So I think ultimately we did well, and I'm going to find everybody satisfied.
Okay. All right, let me separate the question then. Mm-hmm. All right, specifically in terms of meeting with the associations, their salary, like the back pay or the increase, the retroactive then. Mm-hmm. What would have caused the delay in meeting with these groups so they would have to take industrial action?
Well, first of all, remember it's not the Ministry of Health that negotiates salary, it's the Ministry of Finance. So we don't, while we attempt to facilitate and certainly empathize with the groups, and there are about 34 bargaining units in health, so there's a lot of groups. It is the Ministry of Finance that actually negotiates packages. So that question may be better directed at directed at them. But the compensation review was a very comprehensive process. It involved all bargaining units, and it took some time. So I would imagine that they would say that it was a very complicated process, and ultimately I think the workers won because, well, not won, but they benefited because of the size of the increases and so on.
Okay, Minister, thank you very much for taking time out.
Let me ask you a question. How is KPH going? I hope going on all right?
No, not all right. KPH is always overcrowded and understaffed. So we probably need to get the figures.
Well,
right?
You may have heard my announcement recently that we're going to build a new KPH. We're negotiating some land now. But there's also some move afoot to renovate a number of the existing structures, operating theatre, ICU, some wards. So KPH has done a really good job, and I want to commend you and the people there, because truthfully, without KPH, things would be so much worse. It's a primary trauma center in the Caribbean. So, despite the challenges, big up to all of you.
All right.
All right?
Thank you
all
very
much.
Be sure to subscribe for more informative contents on life, sickness, and death.